Hey, good morning and welcome to Friday Chalk Talk. My name is Patrice Fidel. I am the moderator for today. Today we have the pleasure of, I have the pleasure of introducing Dr. Amy Dellinger Page. Dr. Page joined the faculty of Appalachian State in 2004. During her tenure, she served as undergraduate programs director, internship supervisor, and department chair, and is currently the undergraduate programs director. She was a member of the inaugural Interpersonal Violence Task Force and later served as a member and co-chair of the Interpersonal Violence Council. Her research interests involve attitudes about women and rape, pornography, and its role in promoting rape culture, prevention programming related to interpersonal violence, sex offender policy, and toxic masculinity and its relationship to violence. For the past 4 years, she expanded her research interest by studying end-of-life doulas, which she is speaking about today. Dr. Page works with OASIS, the local domestic violence and sexual assault crisis center, on sexual assault prevention programming with alcohol-serving establishments and faith-based communities, as well as the Office of Access and Equity at Appalachian State on Title IX and sex-based misconduct cases. Amy, thank you so much for being here, and the floor is yours.
Thank you so much. I really appreciate you all having me here today to talk about end-of-life doulas. It's something that I feel very passionately about and may seem very disconnected from sexual violence and interpersonal violence, but I seem to like talking about things that no one else likes to talk about and often feels uncomfortable talking about. So that's kind of what brings me to this work, and I'm gonna dive in. This is gonna be a little bit informal of a conversation. I'm just gonna try to present some background information and then leave some time at the end so that we can have more of a conversation and I can try to answer some questions. So I'll just start by saying that end-of-life doulas really grew out of the birth doula movement. And so a lot of people are very familiar with birth doulas, but not so much end-of-life doulas. The easiest way to think about this is if you are familiar with birth doulas and sort of the reason that they came into being, it's very similar for death doulas. And it's the ushering out of life and sort of removing the medicalization of a natural process, or at least trying to get it back to a natural process is sort of the impetus for it. It's very client focused and it's very individually tailored. So doulas are very good at sort of removing their own biases and belief systems to focus on what the dying person wants, and sort of recognizing that there are different meanings and traditions related to that. So it's very interculturally aware also. And it's very holistic. So it doesn't just focus on the physical, but also on the emotional and the social and spiritual needs. And oftentimes, individuals who contract with doulas are wanting to have conversations and sort of explore potential meanings that they may not feel comfortable doing so with their family or their closest caregivers. It can also allow time, depending on when they get referred to a doula or when they find a doula, to sort of create legacy projects, develop planning, get legal documents in place. Legacy projects are things like, the best example I can think of is I really like to cook and I cook with my family. And so I might create a legacy project where it's a collection of our favorite recipes with me and my family as something to sort of leave behind as a remembrance. So end-of-life doula care is really kind of an emerging field of healthcare. It's been around since before the pandemic. The group that we worked with to collect data is EOLD, the International End-of-Life Doula Association. They're the largest training body in the country. They are certainly not the only training body, but they are the largest. And it came about in 2015. And it was co-founded by a licensed clinical social worker who worked in end-of-life care with hospice, and he went to a birth doula training and thought, there's a lot of application that we can use here for end-of-life processes as well. And so that's sort of how EOLD came about. We wanted to partner with them for the research because they were the largest body, and they also had a really extensive training process that we thought was more representative of what end-of-life care actually looks like. And they have a good relationship with hospice and palliative care practitioners. And so end-of-life care in terms of doula work is really meant to sort of bridge the institutionalized medical care that individuals receive. And so they can act as a supporting conduit. They're not meant to replace medical care. They are not medical care practitioners, although many have a background in medical care. But the ideal is that they can actually help spend time with patients explaining medical procedures that practitioners may not have adequate time to spend with them due to other institutionalized constraints. They can serve as sort of an advocate and a conduit. And in some places, larger cities, they actually work within and on those multidisciplinary teams that often comprise care. They really focus on creating what's called a good death or a meaningful death by being that advocate for the dying person. And again, this isn't only with medical personnel, but also with family members who may not have accepted a diagnosis yet, but the dying person has. And so they might be sort of in different places with that. They can also focus on creating what's known as a death plan, which is similar to a birth plan. This is ideally what someone wants to happen in the last few days when they're in an active dying process. That can be what lighting they want or don't want, people they want around or don't. Some people want a quiet setting. Other people want a loud, boisterous setting because that's what they're used to in their family dynamic. So it really just depends on what that individual wants. But they outline that with their doula and who can then advocate on their behalf with their caregivers. The end-of-life doulas that we studied, we did I'll just go through this really quickly, but I think it helps contextualize who a lot of end-of-life doulas are. So there were 1,900 doulas that we sent a survey out to. We had 600 complete an online survey, and then we followed up with the ones who said, well, I'm interested in doing a follow-up interview. And we did qualitative interviews with 39 of those. And so most of them were between the ages of 40 and 72. That's where most of them tended to reside. So later in life, they came to this. Most were well educated. We had like 65% who had a bachelor's or master's degree. Almost half had a background in healthcare or some end-of-life field. So that could be a chaplain or a faith provider. It could be a social worker. It could also be many who came from the hospice field. They were pretty diverse in terms of religious affiliation, but what was interesting is that they were far more white and female than we anticipated. We sort of expected that would be the case, but it was even more so than we expected. I will say the asterisks are there because EOLD currently has over 6,000 trained doulas who are registered with them, and they are far, far more diverse. And so this is truly a snapshot in time, and it is no longer the case that doulas are very white and female. It has expanded a lot, and hopefully we'll have some time to talk about that toward the end. So just a general idea of what some of the services are that doulas provide. I sort of categorize these into support services, logistics services, and then what they might do for caregivers, because sometimes they end up serving in this kind of dual role with caregivers and with the dying person. But they often provide a lot of emotional care and support. They can also help, I think I mentioned before about spiritual conversations that they might not feel comfortable having in front of their family or with their family or caregivers. And so they want a place to sort of explore like these larger meanings of life. They may also talk about unfinished business that maybe their caregivers are unaware of. And doulas can actually help facilitate a lot of conversations to help take care of that unfinished business. So when we talked to the doulas, they had a lot of experiences with families who had been separated from one another for extended periods of time, and sort of helping navigate those conversations now that there was a terminal diagnosis. Creating those rituals to mark those special moments, and then advocating both with medical personnel and then also with family to try to honor their wishes for pre and post death. They also help with logistic services, so just completing the medical paperwork that can be very cumbersome and confusing sometimes, legal paperwork, getting those sort of things in place, helping with wills, DNRs, all those sort of things, developing the dying and death plan, and then making final arrangements for what they want in terms of a service or not a service, but also what they want with their body and post death. And then they often help with caregivers, again, before and after death. So they may stay on as grief support and as helping sort of reprocess some of the feelings that caregivers experience post-death. So many of them stay on and work with the families after death has taken place. In terms of how it relates to palliative care, it's really complementary and supplementary to palliative care. So it's just another sort of layer. It is not meant to compete with palliative care at all. The idea is to be a conduit and to be supportive of that process. Many of them came from hospice backgrounds, and so they understand how that shift from the original mission of hospice, how that changed with insurance reimbursements and sort of legitimation in a lot of ways, and how that comes with pros and cons, right? It means that you have less time with each patient, but it also means that you get reimbursed for your services and you can expand who can receive those services. So they can kind of help with that. In larger cities, they are part of those multidisciplinary teams. In more rural areas, they do that work separately, but complementary. They also do have a code of ethics and a standards of practice, at least EOLD does. And again, this kind of varies as to where individuals receive that training and how they market themselves. But EOLD is very mindful of that need to have a code of ethics and a standard of practice. And then they also have 2 levels, training and then certification, which we can talk about in a few minutes. And then I thought it might be good to mention some of the challenges that are often faced by doulas. They sort of do this dual role of they are educators in the sense that they often, since most people don't know about end-of-life doula work and what services they provide, they serve as educators initially to sort of get the conversation going. And so they might do that through death cafes. There are some death brews now where you meet at a bar instead of a coffee shop and you have conversations about death. It's just an open place where people can feel more comfortable sharing their ideas and having some open discussion. There is a general discomfort in our society around talking about death. People view it as morbid to want to plan and sort of dictate what you want to happen with your body. And this can be a place where that can happen more openly. They also do a lot of education around what's legal and what's okay. So understanding that you can still have a home service and your family members in most states can still engage in ritualistic bathing and things like that to prepare the body, that there are some guidelines, but that is an option. Another challenge is that they're commonly brought in at the point of a terminal diagnosis or actually toward the final stages once people have accepted that they are dying. And so that can be very challenging in terms of like if people are brought in and then they lose verbal capabilities, then it's really hard to make sure you have a good understanding of what that individual wants. And then navigating the structural barriers within the institutionalized settings. So there's also a lack of knowledge within practitioners about end-of-life doulas and their roles and their care, which is why I'm so thankful that we can do this here. And then gaining the trust of medical personnel, sort of understanding that we're here to support you. We are not here in a medical capacity, but as a supportive role. And I'm saying we because my colleague and I actually went through the training to be end-of-life doulas, just as a way to really understand what that training looks like and what the work entails, and to hopefully be a better reflection of that work in our publications. And then just understanding and learning the specific bureaucracy of individualized settings. Every place has commonalities in terms of that structure and politics, but also there are unique differences in every one of those settings. And so that can just be a barrier in terms of getting on board. And I think that's it. So I'll open it up to questions. I'll tell you that I removed my phone, so I don't even know what time it is. I hope I did well on time. I didn't want any distractions, so.
You are fine on time, so thank you. I don't see any in the chat yet or any raised hands, so I will ask my first one, then I'll turn it over to Martin. My first question is, I noted in both your paper and your presentation that a lot of the end-of-life doulas have background in medicine or some other healthcare related discipline. Do you have any insight on how someone navigates the ethics or the conflict of interest perhaps of being an RN but not being an RN for that patient, and perhaps seeing a medical issue and overstepping that line because they're not actually caring in a medical way for that patient? It seems to me that that would put that individual in quite a position.
Sure, I think that's a great question. And I will say the doulas that we spoke with we're very mindful about, not only in terms of medical decision making, like sort of understanding when I'm in a doula role versus when I'm in an RN or a medical personnel role. They also understood those boundaries and how to sort of maintain those in family dynamics as well, right? So they want to facilitate this end of life process, but understanding like I'm ultimately here to support a dying person and not to support what the family wants or doesn't want, or what caregivers want or don't want, because those can be different individuals as well, the caregivers versus the loved ones. Many of them that we spoke with had left those professions, and so they were now sort of transitioning into a different line of work. There were some that are maintaining the doula work along with like if they're licensed clinical social workers or medical personnel, but they really talked about understanding this is when I'm in this role, and while I might be able to alert someone to something that I think might be happening, it's my job to go to the medical personnel to say, are you aware of this? Like it's my job in that role to be a conduit and to maybe alert them or say, have you seen this? Have you noticed it? But it's not my job to react to it in that role. So they've been pretty good about that. I think that's where the standards of care, the code of ethics really comes into play. They do a lot of work in training as well about maintaining those adequate boundaries, talking through things if there's a question. And in the areas where they are part of multidisciplinary teams, those are part of the setup conversations. Like where is there a gray line, and where do we need to make sure we're maintaining these boundaries? Because the goal ultimately is to be an advocate for the dying person.
Okay, thank you. Martin, if it's okay, I'll skip you because I do have a question in the chat from one of the many Jens on the call. What type of training do doulas receive first? Can you speak a little bit more about the training?
Sure. So I can talk about the EOLD training. I'm not that familiar. I've seen a lot of things online where you can be trained in as little as 6 hours, which is a little gives me heart palpitations a little bit, because I don't think you can adequately be trained for pretty much anything in 6 hours. Well, maybe a few things, but anyway, for EOLD, the process is around 36 hours of active training. There are pre-modules that you do ahead of the sort of face-to-face training. We ended up doing ours over Zoom because it was that awkward in between, like coming out of the pandemic, but people still not being able to be totally, it was that weird time period. So we did our training in a group together, and we would do breakout rooms, which was a little awkward, but It's a pretty intensive process. So that's 36 hours of face-to-face training plus the pre-work. If you want to then be certified, which is a different level, then you work one-on-one with a trained doula. You submit case notes. They give you feedback. You have to work with so many patients and have supervision and oversight during that process before you can be certified. So most of the doulas with an ELDA are trained but not certified.
Thank you. Martin, you want to?
Yeah. Thank you, Amy. I have a handful of questions, if you'll humor me. The first one is that I was reading your paper and I was struck by how much time these end-of-life doulas potentially could spend with a family. Like here I saw in the course of a vigil, it could be 1 to 4 hours a day. And when they're actively dying, you could spend an additional 3 to 6 hours. That's an incredible amount of time. And it seems like this is a resource that might help bridge the gap for families that want to die at home, but just don't have the support to die at home.
Right.
But the thing that I struggle with is how I think this is so uncommon or not understood. How do you even begin to access this? Is this just I suppose, a Google search in your area?
So it can be one of the services that EOLD provides is you can go to their website and they have a doula directory. And so you can enter your state and your region and it will tell you trained doulas in your area.
Oh.
Again, they are certainly not the only organization. They're near where I live. Has recently been established a Center for Conscious Living and Dying, which is actually a physician who left the practice and set up this center to be end-of-life care. And it's for individuals who want to have more of a community setting for dying. And it's free. It's supported through grants and donations. And so there is medical care available with it, but it's meant to be this more supportive environment for the dying person and their caregivers. And there's a documentary that's out about it. I haven't seen it yet, so I'm always hesitant to recommend things that I haven't actually seen yet. Sure. So there's a variety of ways. I think in rural settings, it's probably a little more complex to find folks. But then we also see that work has been done for generations already. It's just not in this sort of trained and established way. But one of the good things that I think came out of the pandemic was more open conversations about death and dying and what someone wants and sort of making plans. And so I think it's done a lot to help facilitate some of these conversations.
My second question was about race, because I circled that in your paper, that it was 91% female and 90% white. And I was curious to get your thoughts on that and some of the implications on that, though it sounds like things have changed, perhaps.
Things have changed. I think there's a lot more diversity, not just in terms of race, but in terms of sex and sexual orientation. The training that we were on, we felt like was more diverse than anything in our sample, with like 40 of us on there. There are more trans and LGBTQ folks in general getting involved so that they can help folks in their own community and have an intercultural supportive level of care. And I think that's happening with racial and religious background dynamics as well. The more these conversations get opened, I think the more likely we are to see marginalized populations helping do that work for one another. And ELDA is also doing some things to help access to care and access to the training. So they're offering scholarships and some things like that to help bridge that gap as well.
Any idea what something like this costs?
Again, it depends. Like, I don't want to be in an ELDA commercial, but so it can be costly. It can be like almost $1,000, but they offer additional training and workshops now on how to establish a business. There's lots of gender dynamics within this work, I think, as well as racial dynamics, in that Women, I think, are drawn to this work, but also they tend to be seen, doula care, since it's affiliated with women, often gets seen as like, well, this is just your emotional labor. And so it's hard to assign a dollar value to that, both for women to say, these are what my services are worth, but also for people to recognize that this isn't just care work. I mean, it is care work, but it deserves to be paid care work, right? And that it's not just part of our gender role sort of aspect. So there's some interesting dynamics that kind of play out.
Not a role that's all that different from a social worker. I mean, as I read the description, a lot of psychological training, a lot of high tech sort of stuff. It's not just holding a hand, not at all. And living at a nursing home is expensive too. So, there's some trade-offs there.
Correct.
The other thing I was curious about is you talked about having a diagnosis of a terminal condition to see an end-of-life doula. What does that really mean? Because I think of that in a more expansive way, like heart failure. That's a terminal condition, but you might live for years with that. Is this something that can be more upstream, like a palliative care team? Or when we're talking terminal, we're really talking like very close to end-of-life hospice?
Oh, I'm so glad that you asked this clarifying question. So I think the challenge is most end-of-life doulas want to have those conversations like with me. I'm almost 51. I don't have a terminal diagnosis, although, at the moment we're born, we all have a terminal diagnosis. Like, it is a fact of life that we will die, at least currently. And so, but I think most people don't think about it like that. And so doulas would prefer to work with people without a terminal diagnosis. They would prefer to work, like, think about and be able to have conversations and have time for legacy planning, all of that before you're dealing with something that's more imminent. Because you're right. I mean, part of the reason I was interested in this topic is I had experienced some recent deaths in my family that sort of ran the gamut. My father had a pulmonary embolism and died suddenly. My grandmother lingered in a hospice facility for months, at least a month beyond what all the medical doctors were saying she should, which I think was just general stubbornness. But there's this wide variety. And so doulas would prefer to work with people earlier on. It's one reason they do the death cafes and things like that, to sort of spark those conversations. But the reality is that challenge of when most people are referred, if they're referred to an end-of-life doula, it tends to come from hospice or some medical diagnosis where someone in that facility is aware of end-of-life care, and then they refer them. So I think that's kind of the challenge. It's not what they would prefer, but that's often when it happens.
Remarkably similar to palliative care. We would love to get involved more upstream. A lot of shared
Correct.
struggle. All right,
And I think that's, sorry, go ahead.
No, please, please, yeah.
I was just going to say, I think it's part of our larger sort of discomfort with talking about death, and that we often see death as a failure of living rather than something different. And so I think that's part of it, is that, and medical practitioners are just like the rest of us, right? Because we're all in the same society. So we all sort of are influenced by that.
It makes me think you guys might have to change your name. I mean, if you call it an end-of-life doula, then you're sort of pigeonholing yourselves. Whereas, just like we struggle with, should we continue to call ourselves hospice and palliative care? Because we kind of are associated with that for more upstream. But anyways, one last question, and then we'll let you go. You have 2 published studies on this. I know you're working on a 3rd. So you have an incredible expansive knowledge on this subject. What was the thing that sort of surprised you most throughout all of this training and literature and work that you've done?
So I think the most surprising part for me is how positive all of the doulas are that we talk to. And it's not that I don't think this work can be positive, but it is very emotionally and physically taxing. to be that support system at an end of life. But every single doula that we talked to for the interviews, and it also came through in the surveys, is that they see this as like talking about end of life means that you live your life more fully. And they all talked about like being this conduit of compassion and care at end of life, and really helping usher someone through. They talked about death as a transition space, not really as a finite thing. And I think that affects their outlook in general on this work. And so it just was, I think there's an easy tendency to think that it's depressing, but none of them found this depressing. They all found it uplifting and positive. And that's not to say they didn't find it challenging at times, sure, but they all came to this and work every day with this very positive outlook. And I will just say, since you mentioned the articles, so we have the third one from this study that's under review, so hopefully it'll come out soon. And we're drafting a new study currently. We wanted to work with doulas first as a way to gain their trust, and to sort of demonstrate that we wanted to represent them well. And then our next study is going to be with dying persons and their caregivers about their use of end-of-life doulas and whether they found that beneficial or not. And so we're also looking to add a structural component to that, to talk with practitioners who've worked with end-of-life doulas, so that we sort of have this well-rounded view of end-of-life care.
Thank you.
Well,
Thank
Amy,
you.
thank you so much for being with us today and sharing all your wonderful knowledge. And hopefully you can come back when you have the third paper and maybe talk to us about that. So
That'd be great. Yeah. Thank you all so much. Please, if anybody has follow-up questions, you're welcome to reach out to me. I'm happy to answer any follow-ups.
okay. Thanks so much.
Thank you.
Great day, everyone.